And let me just move that. And here are some of the objectives we'll talk about. Demonstrate an understanding of the concern of patients and physicians regarding epilepsy and memory loss. I will talk a little bit about the anatomy and or physiology of memory formation and consolidation, just because memory is not created equally. And also sometimes it's nice to see what parts of the brain are involved with memory. Once again, some of the terminology may be a little dense, but it's more of just trying to introduce people to where we're looking at when we're talking about epilepsy and or epilepsy surgeries in the future. And we'll talk about etiologies in epilepsy or the causes of epilepsy that can affect cognition and memory. And then we'll talk about the impact on healthcare and how we sometimes evaluate and treat these individuals. So to start off, we'll talk about just overall memory, cognition, and epilepsy. I'll try and move this out of the way best I can. So in regards to memory, cognition, and epilepsy, there is a higher prevalence of impaired cognitive performance in epileptics when compared to people who are the same age and education level. Why? There's actually a lot of reasons, which we'll go over as the discussion continues. And really, memory and cognition are technically two separate things. When we refer to cognition, we're almost talking a little bit more about potentially their IQ and how functionally they're doing, whereas memory is also functional, but it's more talking about, what we would consider memory. Can you remember what's going on? Can you remember what words you want to say, et cetera, et cetera? And because of this interplay that goes back and forth between these two things, it is kind of an issue for both the patient and the physician in trying to figure out what's going on. So why do we even look at memory, and how did we come to look at memory and cognition and epilepsy? So people who just had severe memory loss, when first were evaluated in the 1900s, we didn't know why. Then they started doing autopsies that actually showed that there's a part of the brain called the hippocampus that was usually involved in people who had severe memory loss. And very specifically, it was shown on both sides. As time went on, there actually was more discoveries that led to memory research. Interestingly enough, most of the best memory research we had was due to epilepsy surgery, which is reserved for people who have medically refractory or drug-resistant epilepsies, where they have failed to appropriately dosed medications for seizures. So to give an example, in 1946, Dr. Wilder Penfield performed what we now call an anterior temporal resection, which means the most frontal aspect of the temporal lobe. They took that out, and afterwards there was much improvement, or not having much improvement. There's a lot of reasons for why that might be. In 1951, they thought, why don't we take out a little bit more and the seizures might stop? And when they did that, they took out more of the midline structures. In doing so, unfortunately, they actually had post-operative global amnesia. So this showed that if you took too much out, it actually was starting to affect the memory. In 1952, Dr. Penfield performed a unilateral left temporal section for a patient with temporal lobe epilepsy. And at that time, he actually had a very famous neuropsychologist named Brenda Milner, who showed that even with this unilateral left temporal resection, there was post-operative memory loss. So after the surgery, they had inability to remember certain details. As time went on, there were other case reports that started to come through. Another famous neurosurgeon, Dr. William Schofield, actually contacted Brenda Milner after seeing the work she had done in 1954, and he contacted her after seeing that there was one specific patient that he had that had a very recent, very grave memory loss per his report. At that time, they were doing these anterior temporal resections, not only in epileptic patients, but also schizophrenic. Most of them had no improvement except for that one patient. Now, who was that patient? Henry Molaison, otherwise known as HM. He's actually a very famous medical case. The reason why they call it the case of HM was actually he was one of the first cases that really started to evaluate personal health information, because his case was so important and so unique that more and more medical journals kept talking about him, but also sometimes identifying him very specifically by name, which, as you can imagine, is not looked favorably upon nowadays, and why we do so much work to protect health information. So HM actually suffered from medically refractory epilepsy after a bicycle accident at age 7. At age 27, he actually had a resection on both sides of his brain, and we'll talk about why that's important, of a lot of structures that are really important for memory: the amygdala, the uncus, the hippocampus, parahippocampal gyrus, and this was all done by Dr. Schofield. Now, it spared a lot of the temporal lobe that's more on the outer aspects, the parts that's closer to the skull, which might make a little bit more sense when we look at some of the imaging. That's what we call the neocortex. So it spared a lot of those regions, which we later now have come to find out might not be as involved in memory as more of the things that are towards the middle of the brain. So this is actually an MRI scan on the right-hand side of his brain. So he actually had these middle aspects of his temporal lobes removed, which were a part of the hippocampus, amygdala, etc. He actually developed a severe antegrade memory loss, meaning that he couldn't take any of his memories and create them for the future. And we'll talk about what that means in the upcoming slides. But he did still have working and procedural memories. So the things that he had learned up until the point of his surgery, he could recall, but trying to form new memories was near impossible. So he ended up having a little bit of retrograde amnesia, meaning trying to remember things that had happened prior to the surgery, but it was only for 1 to 2 years prior to the surgery. He could still remember his childhood. He could still remember his family and friends up until that point. He actually did pass away in 2008 at 82. So just showing you that also he did live a full life in regards to at least his age. His brain was donated to the University of California in San Diego, and then moved to the Mind Institute at UC Davis. So interesting things about him. He could, because of all these things, could learn new tasks and later perform them, but he wouldn't remember when he was taught them. He could do crossword puzzles and fill in any pre-1953 information. And then if told it in the moment, he could potentially fill in details. But outside of that, he couldn't do anything after 1953, almost like it was his own time capsule that he was kept in. And I think this is really important because this was before the time of neuroimaging, like MRIs and CAT scans even, and before we started using extensive neuropsychiatric testing. So really, these were what we use nowadays, especially when we're trying to stratify risk for memory loss in individuals with medically refractory epilepsy. So what is the impact on healthcare with this? Epilepsy in general carries high healthcare costs, which I know has been brought up in many conversations before. There's the direct costs of epilepsy, which are usually hospitalizations, medications, et cetera, ambulances rise. That usually comes in the first years after diagnosis, usually 1 to 2 years. And it depends on what's going on, obviously, what might be causing it, how severe it is, what comorbidities. And then in addition to that, you also have this underlying issue with cognition and memory. And these changes that can occur over time really affect the independence, the psychological health, and the emotional adjustments, which thereby can even worsen memory and cognition down the line. There is a strong emotional impact and effect on these people, and that's due to a lot of the components that are affected by epilepsy, such as the overall stigma, the educational attainment, and driving and job restrictions. There actually was a study that they looked at epileptic patients and non-epileptic individuals from various countries throughout Europe. And interestingly enough, they actually found that epilepsy patients were often better educated than their controls. Lots of theories of why that might be. It might be that they were trying to strive to seek higher education. It's unclear. But with all that being said, they were more likely to be single or unemployed and often less likely to have a driver's license, which, you know, kind of goes with what we talked about with restrictions that they have and also the stigma. Just to give you an idea of how bad the social stigma is, a lot of people don't understand the implications of epilepsy, as we could imagine. This was a neat study that came out of, I believe, Italy, where they did telephone interviews. And almost all of the people on the phone said that they knew about epilepsy per their report, and a little bit more than half knew a person with epilepsy, and almost half had actually witnessed a seizure. Now, with that being said, half of them were unaware of the causes of the disease. More than half said it was a psychological or psychiatric disease, not a neurologic disease. A third thought it was actually a form of insanity. A third thought it was incurable, and probably my favorite, 4% thought it was actually an evil spirit possession. So as you can see, even in the general population, epilepsy can be very poorly understood, let alone the consequences of epilepsy that can affect mood and memory, let alone also their underlying IQ and cognition. So now this will be a little bit more of the dense component where we'll just kind of highlight the anatomy. There'll be a lot of terms that are coming up, but I'll just try and give an overview of the main points to take away from it. So stages of memory. When we talk about memory, there actually are very finite ways that you can take a look at how someone remembers something. So there's incoming sensory information, something you see, something you touch, something you hear. And the first thing our brain does is it encodes it. So we have to convert it into storage. And there's certain anatomic parts of our brain that are in charge of that. Once you have that information, you now have to store it and retain it in memory. And then eventually, hopefully down the line, you can retrieve it. And that's going to be the part that puts it into action, whether or not it's through potentially emotion. It could be a procedure or a skill you may have. It might be remembering a specific date or remembering a part of, your own personal identity. So looking at that, the acquisition. So how do you actually encode and get this information? Here it says the visual and auditory cortex. What that means is your eyes and ears. So that's the first thing. You have to get it, you have to look at it, you have to hear it, and then it goes back into parts of your brain that are usually in the more posterior or back aspect of your brain. And then there's also the frontal lobes. The front of your brain is actually in charge much more with your executive function. So for example, hey, do you think I can jump off this roof onto that roof? You know what? I probably can't. Hey, how long should I take a look at this book and keep reading it for? That's part of the attention that you need to have. As you can imagine, and this is not pointing fingers at anyone, sometimes that's one of the last parts of our brain to really develop. So that's why individuals who are going through adolescence and early adulthood might not have a fully developed frontal lobe. There's theories that it actually fully doesn't develop until you're in your early 20s, like 23, 24. So that's why there's a theory that people are more likely to have drunk driving accidents, do quote unquote stupid things like jumping off of things they shouldn't. But those are the parts that also are needed to help you with your memory. You need to be able to focus on something in order for you to eventually get it to storage. Now the storage, this is the part that actually is the part that you really need to have to retain what you have. So that's more of the actual structural component, kind of like your own hardware from a computer aspect of what is retaining everything. So all of these parts of the brain are what we were talking about before. They're the middle of your brain, near kind of the temporal lobes specifically, and the lower middle part of your frontal lobe. And then a retrieval. Eventually, you need to get this information and put it to use. So how you do that, there's something called the prefrontal cortex, which is really the part of your memory that you're trying to go back and grab all of this information from. And also, there are parts that it has to interplay between these other parts that we talked about, between the acquisition components and the storage components. There's actually a term for this whole circuit. It's called Pape's circuit, who it's once again just named after a famous neuropathologist. But that is your memory and mood circuit. So interestingly enough, you have these structures, but also depending on whether or not it's the left side of your brain or the right side of your brain can affect what it's actually doing from a purpose perspective. That's the laterality that we talk about. In the past 30, 40 years, we've developed better neuroimaging, very specifically it's functional, meaning that it's looking at how the brain's working when it's taking the pictures. So they've shown over time that the left hippocampus is much more in charge of your autobiographical memory, who you are, and your ability to understand language as it's coming through, your verbal memory, more or less. The right hippocampus is actually much more in charge of topographic spatial and more of your visual memory. They actually did a study where, as you can see here, I show a picture of London. They looked at some of the functional neuroimaging of cabbies in London, and there's more these are individuals, as you can imagine, who are hearing everyone's life story day in, day out, but they also need to be able to navigate the very congested, busy streets of London. So they actually saw that depending on what was going on, they could activate one part of the brain more than the other. And that helped kind of even further confirm some of the components of memory. They don't know how much. Sometimes there can be a little bit of both on one side. So for example, a little bit of language might be on the right side, a little bit of visual memory might be on the left. We usually use neuropsychological testing, which we'll show later, to really help define that further. And these are just a list of what we call dominant or non-dominant parts of the brain. Dominant means it's usually where your language is based off of. If most people are right-handed, so the left side of your brain, which is opposite, I know it makes no sense, but it is what it is. The left side of your brain is usually the dominant hemisphere, whereas the right side is the non-dominant hemisphere. As you can see, there's a lot of implications of what each part of the brain is really doing. So the dominant part of your brain, the language part, when it's in the temporal area, it's in charge of the ability to remember words, a lot of your verbal aspects. It can even recall geometric figures. When we go further back, your parietal lobe is more in charge of your vision and spatial recognition of where things are in space. It can even be more complex. It can look at even how do you recognize what a face is of someone that you should know, such as favorite. They've done studies looking at favorite well-known celebrities. Oh, I apologize. Sorry about that. Let me see if I can bring this back up. Okay. Is everyone able to see that okay?
Yep, we can see.
Okay. So those are some of the components of it as well. Now, I've been using the terms cognition and memory just to kind of further clarify what those are. So cognition, per the dictionary, you can't have a slide without having something from Webster's dictionary. They say of, relating to, being, or involving conscious intellectual activity such as thinking, reasoning, or remembering. Meanwhile, memory is considered the power or process of reproducing or recalling what has been learned and retained, especially through associative mechanisms. This is a fancy way of saying cognition we usually use to say, how can you take the information that you've learned throughout your life and put it to use? Thinking, reasoning, remembering. Sometimes we might consider this to be someone's IQ. No one is ever defined by a number. It could be how they function throughout the day-to-day life and perform tasks. That could be another component of it. Memory is kind of a component of cognition. You can have people who have horrible memory, but they might be very, very bright considering, and might be very, very high functioning. You could have the vice versa. Someone might have a great memory, but their cognition is very low. Memory is more about being able to just recall pure data and reproducing it. So there are different types of memory. We'll go through this kind of brief. There is your more short-term memory. We call this your sensory memory, working memory. A lot of what you're doing is storing whatever you see and hear and being able to immediately put it to use. It can be where things are in space. Like, for example, I probably shouldn't turn to the right because I know someone just walked over there and I might bump into them. Central executive, it might say the same thing like, oh, I just touched that hot pan, or I see that that pan is in the oven. I shouldn't touch it because if I do, I'm going to burn myself. Realistically, with enough time and seeing it potentially frequently, you can convert that into a long-term memory, which is why we're able to know I shouldn't touch that pan if it's in the oven, because pans in the oven could be hot. Your long-term memory gets broken up into multiple different components. You have your declarative memory. That's usually your episodic. So that's kind of your own individualized time travel. So that's where you can remember back to times when you did X, Y, and Z. And then you have semantic memory, and that's just knowing about the world around us. So that's, like we said, knowing that, for example, heat will make metal hot and that kind of thing. Episodic memory is more of remembering maybe to a Christmas that you really enjoyed, for example, or something along those lines. And then you have non-declarative memory, which is technically a more important, if you really think about it, because this is how you learn to do your day-to-day functioning. So this is how you learn how to do habits, your motor skills, where you know you are in space, but also knowing how to use that. This is, things that you've learned through time. Someone who has been performing the same task over and over again, like a guitarist or a violinist, etc. They would have, that would be procedural memory, your skills and habits. And as you can see on the bottom, they actually mentioned some of the specific structures, which are a lot of the structures that we've already talked about. This is interesting because this is actually preserved in amnesia. So people might not know anything else, but they'll know, for example, how to still ride a bike, or still play an instrument, or still know how to even potentially cook or do some more complex things. Some factors, and I always talk about this with people who talk about they have memory issues. It's complex. Even slight structural disruption can alter the network. That's why sometimes we'll get imaging in people who have memory issues. But realistically, there's also, when you look at something, you need to know, how long did you look at it for? How distinctive is what you're looking at compared to your day-to-day life? Can you predict what might happen next? And also, is there significance? It could be motivational, it could be emotional, it could be cognitive. So these things really, for example, if you're seeing one word that means nothing to you for the first time, and then you hear about it a few minutes later and ask you what was it, you might not remember it as well as something that you clearly made an association with, for example. Now, very specifically with our epilepsy patients, we'll talk about some of the causes of memory loss and also cognitive change. And we'll break them up piece by piece. So as you can see, this is a pretty good sized list. Really, when it comes down to it, there's two main things. One is the seizures themselves. So the seizures themselves can cause memory loss and cognitive change. It's because seizures are an electrical abnormality and they can cause dysfunction. What's causing the seizures or the etiology of the seizures? Is there anything in the brain very specifically that is causing the seizures? Because if it is, and it's in one of those locations that we mentioned, such as the hippocampus or the mesial temporal area, which, by the way, is a very common cause of epilepsy, mesial temporal sclerosis, for example. But any of those areas might affect certain types of memory. What types of seizures do you have? Do you have a focal epilepsy, meaning you have what used to be called partial seizures, where they come from one part of the brain, or are they generalized? Things like absence or generalized convulsions with no other types of etiology. How old you are when the seizures start, how frequently you have them, how long they are, or technically severe they are. And then you have, outside of the seizures themselves, you have other factors, such as hereditary factors. If you have a very well-known family history of dementia or other cognitive delaying issues, that could affect it. Psychosocial. If you don't have, if you potentially don't have, you come from a low-income area, you come from an area that depression runs rampant or anxiety, these can affect it. And then you also have the interventions done by physicians. So epilepsy surgery can cause memory loss. We'll talk about that a little bit in the future, in the near upcoming slides, but that could also help memory. But you can be put at risk of memory loss. The medications themselves, you have to come up with a fine balance of how much medication you want to give and how much you want to kind of hold off. Is it really bad or good that the seizures are happening? Once again, we'll talk more about that. Physiologic changes. So this is actually what's called a PET scan, where they're looking at the blood flow and metabolism of parts of the brain. Parts that are red are receiving a little bit more blood flow. As you can see where the arrow is pointing to, this is an example of after a seizure has happened, blood flow might decrease in a certain part of the brain where the seizure may have happened. So here you can see that's the left side of the brain. I know it looks backwards comparatively, but that's the left temporal cortex. And that's actually showing that its metabolism is lower. It's getting less blood after the seizure. Now, it will get blood flow again. I don't want people to immediately get upset saying, oh my God, my brain's not getting blood after a seizure. It just means that it's not getting as much. Now, usually the blood flow is preserved enough. Your body has mechanisms to help preserve any tissue that's there. It's not quote unquote dying off. But with that being said, someone who has very prolonged seizures, what we call status epilepticus, that's where the concern comes in, that this is actually going to potentially cause specific damage. It can lead to anoxia, lactic acidosis, so production of lactic acid, which can cause some damage to tissue, and excessive excitatory neurotransmitters. So it's releasing chemicals in your brain that makes it a little bit too excited, which can cause tissue damage. Now, once again, the caveat with all this is, like I was saying, people who are in status epilepticus, they have done a lot of studies on this. Realistically, right now, we always say status epilepticus is a seizure lasting. We treat if it's after 5 minutes, but treating what we call status epilepticus is technically a seizure after 30 minutes. That's all based off of mice models, potentially. And realistically, that was only seen with generalized convulsions, which very, very rarely happens. More often than not, someone has a focal seizure that's prolonged, or a focal seizure that led into a generalized convulsion that goes away, but they're still having small focal seizures in between. They've tried to do studies on focal seizures that are repetitive. The thought is it could be maybe if they're doing that for days, there could be a risk of damage. So I just want to put that just so people aren't very, very concerned that every time they have a seizure, this is damaging their brain. It could be altering things though, which as you see here, it does say frequent temporal lobe seizures may increase hippocampal atrophy. So like we were saying, we don't completely know everything about this. The thought is one is called kindling. If people have seizures for a prolonged period of time, it can actually train other parts of your brain to start having seizures. That can be problematic, especially if they're an epilepsy surgery candidate. We don't get it in time. We might not be able to do a resection because we don't want to take out both temporal lobes, because that's like the case of HM. It also could directly affect memory formation, because if your temporal lobe is highly associated with memory, you're having seizures there, you might not be able to do any of the encoding, or you might have difficulty with retrieval because you never encoded it or stored it, just because you're constantly seizing. Seizures in sleep also might affect memory formation. There's been theories. The actual etiology of seizures, what's the cause of the person's seizures? Alzheimer's dementia and certain types of dementia actually can cause epilepsy. A lot of people don't necessarily know that, but that is an important thing. So if you have dementia, that already is going to put you at a little bit behind the 8 ball for memory. Focal lesion, so a very specific area of the brain that's causing epilepsy. Like I said before, it might cause memory issues if it's in the temporal lobe, for example, or in the parietal lobe in certain areas, or in the frontal lobe. We usually use neuropsychological testing to really help identify that. Interestingly enough, idiopathic generalized epilepsy patients tend to have actually a normal to slightly higher IQ than the general control, the general population. This is in comparison with syndromic epilepsies, which typically have depressed IQs. These are the people who might have a genetic predisposition. An example would be people who have juvenile myoclonic epilepsy, or JME, is it idiopathic generalized epilepsy. They typically have normal to high IQ, versus someone who might have infantile spasms that goes on to have Lennox-Gastaut. They usually have a depressed IQ, which can be quite significant. An important thing that is, regardless of whatever type of epilepsy they have, typically, not always, the earlier the age of onset, there's a higher chance of cognitive impairment, so affecting their IQ. It's not a guarantee, because as you can imagine, there's childhood absence epilepsy, for example, which some people quote unquote grow out of. They might not have cognitive impairment, but this is an important thing that has been demonstrated, or important trend that has been demonstrated. The actual seizures themselves, if they have generalized or complex partial seizures, while the seizure is happening, their cognition is delayed. So that's actually one way that we look at to make sure that people aren't seizing when we're talking to them. So if they're, for example, very out of it, quote unquote, they might actually be having a bunch of absence seizures or behavioral arrests because the seizure is happening while you're talking to them. So they can't, their IQ might appear lower. They might have difficulty expressing themselves, etc. This is a little controversial. Epileptiform discharges and postictal suppression can impair the interictal cognition. So that means in between seizures. They're not seizing, but maybe it's affecting their cognition. The postictal suppression means after the seizure is done, your brain kind of shuts down a little bit just to kind of rewire itself. So that would make sense. The epileptiform discharge component is what is controversial, because what we define this as is things that we see on an EEG, such as a sharp wave or spike. It usually means that it's not a seizure necessarily unless we see some clinical aspect. For example, if they had a jerk when we saw one spike, then we call that a seizure. If we don't see the jerk, we just say, oh, it's just a spike or sharp wave, meaning they're at risk for seizures. If this is actually technically affecting their cognition, there have been theories that maybe it should all be in the same field and just all call it seizure. The reason why that's controversial is that means, do you treat the EEG? And I don't know if anyone's neurologist or epileptologist has ever talked to them about that. That can be very, very controversial, especially with epileptologists, because you don't want to necessarily do that for some reasons that we'll talk about in the upcoming slides. Recent temporal lobe seizures can obviously impact memory. Hippocampal interictal discharge could potentially impair memory recall. That's the same thing with what we talked about before with epileptiform discharges. And then the postictal cognitive dysfunction, so how they're functioning and potentially not their IQ, but how they're managing day-to-day activities, that could happen for a few days. So for a few days, they might be out of it and their cognition might appear lower, meaning they might be fatigued, but they also might appear kind of quote unquote dopey a little bit. How long the seizure lasts? There have been theories that status epilepticus, so these prolonged seizures that last for hours to days, might cause more cognitive decline than just multiple generalized convulsions. Now, with that being said, there are certain parts of the brain that if you damage them, or there are certain parts of the brain that if you have status epilepticus, the prolonged seizures, it might damage them. These are areas that are very sensitive to oxygen changes, and that's why they think that would happen. So like the new parts of the brain, the parts on the outside, the cerebellum, the thalamus, and as you can imagine, the hippocampus, which we talked about, are vulnerable. And focal status epilepticus, which was where I was saying one part of the brain is seizing for a prolonged period of time, it's not necessarily as detrimental as a generalized convulsion lasting prolonged periods of time. So realistically, the real tricky part, and this is where we go back to kind of what I was talking about before with how aggressively you want to treat the EEG or treat the patient. Seizure meds in themselves might actually affect your memory and cognition. It's a new medication. It's a drug in your system. So there's a lot of reasons. There's been theories. Could it be because of their education, their parental IQ, the dose of the medication and blood levels, the maternal age and how many children they've had? And then you also have your socioeconomic status. All of these make it very difficult for us to completely evaluate how much this is affecting, how much these medications are the only thing affecting these people's IQ and memory. There is an increased risk of intellectual disability in children of a mother with epilepsy. So people who are on seizure meds, if they're born to a mother taking seizure meds, intrauterine growth retardation, IUGR, reduced head circumference, malformations such as cleft lip, cleft palate, all can be associated with AED exposure. So I want to see if just showing you two animal studies have been done. So this is one where we can kind of control as much as we can because we don't have to worry about things like socioeconomic, et cetera. They have shown that in the first trimester of a pregnancy, that's your highest risk of anatomical deficits from taking seizure your third trimester is where it becomes more functional, meaning what their IQ could be, etc. And how does this happen? There's been theories certain medications will degrade folic acid or folate quicker. Folate is very important in the development of the brain and spinal cord. It could be ischemia, reactive intermediates, meaning these oxidants that could potentially damage the brain. Parts of the cells might die. So realistically, things that are that might cause that have been potentially, specifically valproic acid, which we'll talk about in a second, and also taking multiple meds, except with the exception of levotirazine. I will put the one important note is that with all of this being a concern, it is a slight risk. And all of my patients who have who are pregnant, who are on seizure meds, it is far more important for them to be on the seizure med than for them to risk having a seizure while pregnant, because a seizure while pregnant will significantly increase the risks of things such as ischemia, neuronal suppression, apoptosis, meaning it could put the baby at risk of being stillborn or a miscarriage. So I just do want to say that. I know this might seem a little scary, but it is very important to keep that in mind. Just going back a little bit further, to show that there have been studies that talk about this. There was studies that were done in 1995 in Copenhagen, where they actually looked at some of the older meds at the time, which, well, at the time they were the more important ones. Phenobarbital. They did show that phenobarbital, when used, did actually have the children who were exposed to that actually did have lower verbal IQ scores. And it was up to 7 points in those exposed. Now, with that being said, interestingly enough, the people who were on phenobarbital usually were of lower socioeconomic status, and they were actually considered offspring of being an unwanted pregnancy. For those individuals, it actually increased their IQ deficits by almost 20 points. So as you can see, there's a lot of things at play. It wasn't only the phenobarbital that could potentially affect their IQ. It could be the socioeconomic status. It could be them being an offspring of an unwanted pregnancy. And the exposure in the last trimester was the most detrimental. I can't say for certain that people would come off of phenobarbital at any point during pregnancy too, though, because phenobarbital could be devastating if you just stop. It can cause significant withdrawal seizures. So there have been other studies that have tried to compare other medications. For example, this was a study out of 2015, where they actually looked at children born to women with epilepsy and children born to women without epilepsy, and they looked at full-scale IQ. The full-scale IQ in general for children of women with epilepsy was lower than that of children of women without epilepsy by almost 8.5 points. And that's important too, because an IQ less than 70 is usually what we typically consider intellectual disability, which has various degrees. So looking at just monotherapy, meaning one medication was used, phenobarbital actually had some of the highest risk. Whereas in this study, they showed that valproic acid, carbamazepine, phenytoin had roughly about the same. Some predictors of lower IQ, low body mass, and low maternal education. And then if they had a high anti-epileptic drug in addition to dosage, in addition to that, and then also there was actually some correlation with low paternal education as well. They also showed that attention and memory, though, were also significantly lower for children born to women with epilepsy. There's a study in 2013 called the Neurodevelopmental Effects of Anti-Epileptic Drugs. This has actually been a long-standing study. This one actually showed that valproic acid, because they didn't check against phenobarbital, it had already been well established, valproic acid could also specifically affect verbal and memory abilities. They compared these people to people who were on carbamazepine, lamotrigine, and phenytoin, but valproic acid showed the most effects, and specifically they said it affected IQ, verbal and nonverbal ability, and also memory and executive functioning. Interestingly enough, they actually showed that if you were exposed to valproic acid, they also saw there may have been reduced right-handedness and verbal issues, which they thought was due to cerebral, they thought it was actually the drug itself was just causing changes in the brain structure. With that being said, that's one of the reasons why any woman of childbearing age, I personally and most epileptologists will try and maybe get them on to another medication that might carry less risk, like levetiracetam or lamotrigine. If that's the only medication that truly helps them, then we just have to talk about the risks, and we usually supplement them with folic acid to help out a little bit more. And that's why right here you can see mean IQs were higher in children exposed to periconceptional folate than those who were in unexposed children. And it's by almost 7 points on the IQ. So it's kind of important. So that's why I make sure anyone who essentially has had a menstrual period at any point in their life gets started on folic acid. And then to also represent our aging population, they actually did look at multiple medications. This was an older study from the 80s. They compared carbamazepine, phenobarbital, phenytoin, primidone, and they found that their epilepsy was actually easier to control compared to younger individuals. But they found that if they had new onset epilepsy, which is very common in people over the age of 65, mind you, from things such as stroke, tumor, dementia, they saw that they were much more likely to stay on gabapentin or lamotrigine than on carbamazepine, which I just thought was kind of an interesting note. So they tried to make sure that they were on medications that already had a low side effect profile. They didn't have to be monitored as extensive. So this I will be brief on because I know we're coming up towards the last about 12, 13 minutes. So how do we evaluate this? I will give you a list of all the extensive testing that our neuropsychology colleagues use. I won't go too far into them, but I do want to show just kind of the extensive battery of tests that can be used to evaluate our individuals with epilepsy, and also talk about why we do it. So you have to evaluate all of those components that we talked about before, the encoding, the retrieval, the storage. We can do things like immediate recall. So you give them a list of numbers, have them repeat them back immediately. You could have recent memory. So give them the list of items and then have them repeat it back a few minutes later. You want to make sure, do they know where they are, what year, what date it is? And then there's the remote history. So that's the part that's much further, that's longer back in time. It doesn't mean that they don't have to worry about being able to still learn new information. They need to know if they can recall material. And very specifically, and this is important, you want to know what material they can remember. Sometimes it can be cultural. So you do want to make sure you understand what they should remember. So for example, if they're from another country, they might not be able to recall certain cultural components of, for example, the United States. Their educational background. If they graduate from 10th grade, or not graduate, their highest level of education is 10th grade, they might not be able to recall nearly as much or have a better remote memory as someone who went through high school or someone who finished college or graduate school. These are just a list. This is just a very, very quick overview, just showing that there are a ton of tests, for lack of a better word. And when they're going through this, it's important, as you can see, they're looking at intelligence, memory, their achievement, verbal tests, frontal or executive functioning, parietal lobe tests, so where things are in space. And then they also, at the very end, you can see, they also want to know, is there anxiety and depression? Because that can almost create a false sense of memory loss, because when people have anxiety or depression, they might not retain what you're saying because they might not be paying attention. They have more on their mind. They might be down on themselves and they just don't want to put in the effort, quote unquote. And then same thing with anxiety, they might be thinking about multiple other things that aren't relevant to the task at hand. So that kind of helps us and gives us a better idea of what validity we're looking at for when doing all of these tests. So the IQ score, Wechsler's intelligence scale, It's supposed to determine the overall intellectual ability or intellectual quotient, as IQ stands for. And it's looking at very specific cognitive domains. Actually, interestingly enough, Dr. Weschler defined intelligence as the global capacity of a person to act purposefully, to think rationally, and to deal effectively with his or her environment. This is an older test. I actually put in her. He did not put that into the definition initially. It's interesting when looking at this because there is some subjective component of this. To think rationally, for example, is kind of vague. It can also be altered by things such as anxiety and depression. Looking at it, there is a lot that goes into when we are trying to evaluate someone's IQ. So as you can see, there's a lot that they have to do. And just to show you some of the tests, hopefully this won't be a cheat sheet for anyone that needs to take any IQ tests coming up. But you look at things like how to put together blocks and create patterns. You get a series of tests and try and see if you could figure out what would be the next pattern. Can you put puzzles together with very specific components and tell them where they go? And I do apologize, this is kind of faster, but it was more because I just want to make sure I get to the last few slides as well. And let me see if this, and then coding. So like if they have a key, can they follow the patterns? There's also specific memory scales. There's visual and auditory learning tests. So for example, repeating words back. You give a list of words to them. Can they repeat them back 30 minutes later? This lovely design, the Ray Osterith complex figure, they are given this image, allowed to look at it, and then it's taken away and they have to try and by memory draw this. So as you can imagine, I don't know how many people could do that now, but that is essentially what they're kind of looking at, seeing how closely they can retain and remember this information. And then the wide range achievement scale is different from the IQ test because this is where you really want to see what acquired knowledge they have. So this is kind of seeing not how they can deal with quote unquote on the fly when they're giving something new, but how able are they to perform tests in general. Sorry, I keep having things pop up on my screen. So now coming to the end, how do we really treat this? How do you treat memory and cognitive issues for our epileptic patients? Is there treatment? So it's limited, to be completely frank. How do we manage this? It's kind of a struggle because really you want to make sure they're not seizing for the reasons that we've mentioned. Plus, you just don't want them to have seizures in general. But you also want to really give them the best opportunity to have the highest IQ or cognitive functioning they have, and also be able to remember things so they don't put themselves at harm's risk way, and also make sure that ultimately it doesn't lead to things such as depression and anxiety. So there is the anti-epileptic drug strategy. So really what you want to do is you want to change the regimen to the less cognitively impairing medications, which we've already talked about some examples. You want to use the lowest effective dose. You don't want to make them seem almost drugged. There are a lot of medications that can make people feel very dopey. And as you can imagine, that's going to decrease your attention span. It's going to make you feel less involved in conversations, and ultimately might make your memory worse. Realistically, your hope is to have only one medication on board. That is not always doable, as we know. There are people who are on multiple medications, which we'll talk about in a second. And this is also why I highlight this, to go back to that component of how aggressively you treat an EEG. So when we look at those spikes and sharp waves, do you really want to slam them, quote unquote, with medications? No, because you don't want to hit them with so many medications that now they have memory issues or attention issues and potentially cognitive issues if they're young enough. Surgery. So if they do fail the medications, really you want to stratify pre-surgical risk. You don't want to remove a part of the brain and then have their memory get significantly worse. So that's why we do the neuropsychological testing, neuropsychiatric testing. We want to see what side of their language is more involved in by that battery of tests that I just showed. You want to get imaging to see if there's any kind of lesion that might be causing it, or any dysfunctional areas of the brain. There is a high risk if they if there's a high risk of post-surgical memory issues, if there was a high memory performance on the right and low performance on the left with WADA testing, meaning that the left is your dominant hemisphere. So if you already have verbal issues from the get-go and you take out that part of the brain, you're going to have even more verbal memory issues. You'll have difficulty remembering what people tell you, how to really encode it, retrieve it later. You want to make sure that there isn't an area like there's an area of the brain that actually does look pathologic, that if you took it out, it's already pathologic from the get-go, such as the hypometabolism on the PET scan of the left temporal region. And you also want to make sure there's not, the left temporal region isn't heavily involved in memory. You want to make sure that you're not taking out too much of the brain if they have seizures coming from there, because the more you take out, the more risk there is of hitting memory areas. So what we call a selective amygdalohippocambectomy, or an SAH, carries less risk than what we call an ATL, which is an anterior 2/3 resection of the temporal lobe, because the anterior 2/3 is taking out that whole part of the temporal lobe, whereas amygdalohippocambectomy, or an SAH, is taking out just the smallest parts of the hippocampus and amygdala, and not the rest of the circuitry. And you also want to make sure maybe stereotactic laser ablation rather than someone doing a craniotomy, meaning they remove part of the skull and removing large parts of the brain. This was actually, I think this actually got misplaced. This was just another test, just showing also the seizure duration component and how this was important. I'll actually skip over this because this is just telling you what I said before. It's interesting because people think epilepsy surgery and they say, why are you taking this part of my brain? It would make my memory worse. But interestingly enough, there's actually less likely cognitive dysfunction following the surgeries. And the reason why is because you're taking away dysfunctional tissue. And you might improve their overall cognition and memory because they're going to have less seizures after the surgery, and they could potentially be on less medications. There is surgery-specific postoperative cognitive deficits, as we said, which could be naming and verbal memory, naming proper nouns, recognition of famous faces, or where things are in space and time. So that does have to be monitored pre and post surgery, but it is important to keep that in mind. Neuromodulation. So on the left, we have a vagal nerve stimulator, and on the right, we have what's called responsive neurostimulation. There's also deep brain stimulation, or DBS. These are non-operative, non-intracranial operative, meaning resective options, but they've actually been shown to potentially improve cognition and memory, being that you're decreasing seizures. Now, they've shown in the VNS that they looked at quality of life, or QOL components, and they looked at multiple different variables, and they looked at alertness, verbal communication, memory, social professional achievements, mood changes, post-ictal state, and cluster seizures. And after the VNS is placed in individuals, they actually showed that memory showed the least improvement rating compared to other metrics, whereas they showed alertness and post-ictal state showed the most improvement. So it's to be taken with a grain of salt. VNS could potentially improve memory, but patients might not appreciate it as much, and or they might already have such deficits that they can't really see a difference. But with that being said, they feel more alert, and after they have a seizure, it's much shorter. So maybe there is benefit. They've also shown that actually testing these people, however, there is improvement. They've shown that the VNS has shown reduction in errors relying on working memory. So even though patients might not appreciate it, it does improve their memory. And it also increased more visual attention to objects. It did cause a little bit of a longer reaction time, but overall, people did much better with VNS than without. And later on, more recently, they've done more and more studies, and they've actually shown that when looking at 37 different patients, almost half of them actually reported an improvement in quality of life overall due to reduction in seizures and how they were doing functionally. So, I mean, they might not think memory improves it, but it does seem to. And just ending up, this is kind of interesting. They've shown that when you actually stimulate very directly to the brain, it actually could improve people's ability to remember things. That's long and short of what this says. This can actually be done with what's called deep brain stimulation, but ironically enough, the studies are mixed. They've actually shown that memory impairment is actually one of the main side effects of DBS and can be a side effect in RNS, responsive neurostimulation, as well as depression. So even though our studies might show one thing, sometimes the actual clinical data can be a little bit different. So just showing it, memory and cognition can be impaired due to a lot of these different things, as well as multiple factors leading to memory and cognition impairment. And really what we want to do is just overall provide the best seizure medication regimens and also try and provide appropriate epilepsy surgery techniques if they fail medications and can't really tolerate any others. And that's pretty much everything from my end.
Thank you so much. That was awesome. And I know that I learned a lot, and it was also a nice refresh because I have a background in psychology from my education. So it was cool to see some of the tests for cognition and things like that. So that's just my personal comment. As far as questions go, the only one I got in the chat was a request to share the PowerPoint slides. So I'll connect with you after and ask if that's okay. And everyone, I will share that with you if it is. And I also took a recording of today's session, so I would be happy to share that recording with everyone who is here today as well. But are there any other questions that anyone has? And since we're at the end, I would welcome anyone who wants to unmute and ask their question to feel free to do so. Or you can put that into the chat. And if not, then that's okay. And if you have any questions that come up afterward, I'm going to put my email address into the chat right now, and you can feel free to take that down and send me your questions by email, and I can pass them on to Dr. Lansing and get back to you with a response. Oh, I just did get another question for you, Dr. Lansing. Do you have any comment on the Dartmouth study?
The Dartmouth study?
Yeah.
Which one? Let me see. Which study in particular, if the person doesn't mind asking? It's because I haven't. Yeah,
William, I don't know if you want to unmute or you can go ahead and put it into the chat again.
Hi, it's Hopscotch, Institute for Cognitive Health and Well-Being, and it's a study on memory in epilepsy and exercises for memory.
Oh, actually, I actually don't know much about that, to be completely honest.
I was working with, and I guess still am, with Lisa Sackett. I have her email, lisasackett.phd@gmail.com, and it's double T Sackett.
Okay. So, yeah, I will take a look. Let me see, I'm actually trying to put that in now.
And that's I think I can send you some information about that too. And William, I'd be happy to share any comments with you that Dr. Lansing might have. So we'll connect with that after today. And one more question for you. Someone is wondering regarding the postictal state, if someone doesn't lose consciousness, are there still cognitive effects that might interfere with learning?
So essentially, focal seizures without impaired awareness, or what we used to call simple partial seizures. I think that's kind of what they might be referring to. So a post-ictal state, I mean, they're not all created equally, if you will, but after someone has a seizure, the post-ictal phenomenon of what they're having, it could still affect how they're reacting afterwards. Just because even if it's a very small, brief seizure, which is affecting, for example, maybe they get a sensation of deja vu, or they get a strange sensation that goes down one arm that lasts 15 seconds to 45 seconds. Usually the post-ictal period could be briefer. During that time period, they might be a little quote unquote out of it. It could last anywhere from like 30 minutes to hours. So, I mean, it could potentially affect it. It's a lot of, as we said, it's multifactorial. It's a lot of different things. It could be how recurrent they're happening. I mean, there's also the possibility that if they're happening at sleep and you don't even realize they're happening, that could also potentially affect it, especially if they've been happening since childhood. Because there is also a lot of information saying that a lot of our memory consolidation does occur during sleep. And if you're having recurrent seizures in sleep, it could affect it. So it could, even if they're very small. It's usually not as bad as, like we said, some of the bigger quote unquote seizures like generalized convulsions or prolonged seizures. But most of the time too, if you get, as long as people keep their seizures stabilized, usually they feel somewhat improvement in them overall.
Awesome. Thank you very much. And again, if there are any other questions, just I'm keeping an eye on the time here. I, again, would welcome anyone to grab my email from the chat, and feel free to send those questions to me, and I can get them to Dr. Lansing and get back to you with a response. And I also will be happy to share the recording with anyone who would like it. We do have another question that came in, and just to be respectful of everyone's time, if you would like to stick around and hear the answer, then please feel free. But if you need to hop off, thank you so much for being here, and I wish you a very good rest of your afternoon, and a happy holidays, and a happy new year. So thank you all. And Dr. Lansing, do you want to take one more question?
Yeah, of course. Yep.
Okay. Is there any research on increasing BDNF to repair damage?
BDNF? Don't know what exactly. Oh, is this talking about like supplements and things like that people are trying to?
Denise, do you want to unmute and you can, oh, she said yes.
Yeah. So realistically, we say this to even our patients who are outside of epilepsy. Whenever we talk about memory in general, they've done studies in people, for example, with Alzheimer's or other neurodegenerative things, neurodegenerative entities. We usually do say they've done study after study, and the one thing that's been shown to improve memory is 20 minutes a day of aerobic exercise, which I know sounds kind of, you tell people that and they say, well, I don't want to do that. But realistically, that has been the only thing that we've ever seen specifically improve. And that's even comparing them to other medications like Memantine, amantadine, et cetera. A lot of these other supplements, I think I haven't seen any clear data or cases that have shown it to be significantly improving human models. But if there is anything else out there, maybe.
Good for an 11-year-old girl to take folic acid supplement to increase memory.
Yeah. I mean, yeah, that would, like like we were talking about this before, the folic acid use, especially in any young woman, childbearing age, anything along those lines as well. Folic acid has been shown. I know they've done a lot of people will take B vitamins very specifically. How much is actually directly improving memory versus improving energy versus, I mean, there's a lot of different theories.
All right. Awesome. Thank you so much. And thanks for those really thoughtful questions. That's great. And I'm glad that you're taking advantage of Dr. Lansing being here to answer them directly. So thank you all so, so much again. And again, I wish you a very happy holiday season, the rest of it, and a very happy new year. And our agency will be back next year with more sessions. So make sure you follow us on Facebook if you're not already. You can join our mailing list to stay informed about what we'll be offering. So thank you all very much and have a great day.
Thank you.
You're welcome.
Thank you.
Thanks,
Bye-bye.
everybody.